this is a chart that you should familiarize yourself with. It'll allow you to differentiate between benign and malignant neoplasms. Let's go through it. We've got a nice list of characteristics typically we would look at. We've got some of the definite characteristics of both benign and malignant here. So, some of these characteristics are defining features of malignancy. Some of these characteristics are correlates of malignancy. We should know which ones they are. Differentiation in anaplasia. That is a term that refers the degree to which a neoplastic cell resembles its normal counterpart. We talked about it this morning. Benign neoplasms, we said, tend to be well differentiated. They look like their normal counterparts. In fact, they even behave like their normal counterparts. Benign neoplasms tend to be well differentiated. Even the structure of the architecture of the tissue tends to be relatively normal. Okay? Malignant neoplasms, in contrast, they tend to lack differentiation, i.e., they're poorly differentiated. Even the architectural structure in which the cells arrange themselves generally is atypical. Sometimes malignant neoplasms are so poorly differentiated, you don't even know what the normal counterpart is. In a situation like that, we describe the cells as being anaplastic. Anaplastic. Anaplastic means the cells are so poorly differentiated, you don't even know what the normal counterparts are. Now, differentiation tends to be a correlate. Okay, here it is, a correlate. Benign neoplasms tend to be well differentiated. Malignant neoplasms tend to be poorly differentiated. Could we be wrong based on the decision of differentiation? Yes, we could. That's why differentiation is not a defining feature. It is a correlate. Rate of growth, okay, another correlate. Not a defining feature, a correlate. Benign neoplasms, they usually grow very slowly. In fact, they might come to a halt, and they might even regress. When they regress, they tend to calcify. The way we assess the degree of proliferation is by calculating something called the mitotic index. The mitotic index is equal to the number of mitotic figures per unit area. So, maybe there's 5 mitotic figures. That's 5 cells dividing in a certain area. Okay? That's called the mitotic index. That's how we measure proliferation rate. We measure the number of cells proliferating in a certain area. For benign neoplasm, the mitotic index is generally very low. Also, the mitotic figures not only are difficult to find, but they're normal looking. They're bipolar. So, if you were to look at the tissue of a benign neoplasm, mitotic figures would be very difficult to find. And when you did find a mitotic figure, it would be normally bipolar. It would look like a regular cell dividing with 2 poles. Cells replicate their chromosomes. They pull the chromosome to one pole. They pull the chromosomes to the other pole. There are 2 poles. It's bipolar. Okay? These mitotic figures are normal. Malignant neoplasms, they tend to grow erratically. Usually some parts will grow slow, some parts will grow rapid, but they grow rapidly in certain areas. The mitotic figures, therefore, are easy to find. And when you do find the mitotic figures, they don't look normal. They're not bipolar. They're kind of bizarre looking. Sometimes they might have 3 poles. Sometimes they might have 4 poles. Sometimes 5 poles. But the mitotic figure isn't normal looking. And as a result of the rapid growth and the numerous mitotic figures, the mitotic index will be relatively high for malignant neoplasm. Rate of growth is a correlate. It's not a defining feature, it's a correlate. Benign neoplasms tend to grow slowly, whilst malignant neoplasms tend to grow quickly. And again, we measure the rate of growth by calculating the mitotic index, the number of mitotic figures per unit area. Local invasion, is that a defining feature or correlate? That's a defining feature. This defines malignancy. If you have a neoplasm that locally invades, it's a malignant neoplasm. That is a defining feature. There's no correlations. It's a defining feature. Benign neoplasms, they grow cohesively. they're very well demarcated because they do not invade the boundaries which they push up against. Okay? So they're very well delimited. Okay? They are coherent expansile. Okay? They don't invade. Malignant neoplasms, they do invade. They have the ability to breach natural tissue barriers. Because they do that, they tend to blur their borders. The borders are very blurry and irregular, and that's because they locally invade. If you have a neoplasm locally invades, if I tell you on a test question, there's a neoplasm locally invades, you know you're dealing with a malignancy already. Okay? Defining feature. Metastatic disease. The ability to metastasize, is that a correlate or a defining feature? Definitely a defining feature. Okay? Benign neoplasms do not metastasize, but malignant neoplasms do. And their ability to metastasize is related to their size and degree of differentiation. Their metastatic potential is a function of their size and how poorly differentiated the cells are. The more poorly differentiated the cells, the bigger the size of the neoplasm, the more likely it's going to metastasize. Okay? Metastatic disease is a defining feature. So here are the defining features right here, and here are the correlates. Okay? Those are correlates. These are defining features. You should know the difference between the two. You see a defining feature, there's no question it's malignant. You see a correlate, it's probably malignant. Okay, we're going to take a look at what all this means by way of example. Again, this is the most important chart in the whole lecture, so let's make sure we understand it. Okay? Let's first talk about differentiation. Okay? Here is a section through a malignant neoplasm. It's called a clear cell renal carcinoma. It's a type of cancer of the kidney. It's a type of carcinoma that develops from the proximal convoluted tubule epithelial cell, which is usually a cuboidal cell. The cell loses proliferative control. You develop this clear cell renal carcinoma. Now, if you take a look at this section, you'll see why we generally call it a clear cell carcinoma. A lot of the cells look pretty clear. Now, firstly, all the cells in this section are malignant, belong to this renal cell carcinoma. Now, the function of this renal cell, this epithelial cell that makes up the tubule, is to proliferate and make these little tubular structures. That's what they usually do. Well, these malignant cells are trying to do that. They're not doing a very good job of it. But if you take a look over here, you can kind of see the vague outline of a tubule. Little epithelial cells making up the tubule. They're not doing a very good job, but you can see they're trying to develop into little tubules. Now, usually these cells are cuboidal in morphology. And if I pointed out this cell, you kind of see it's not exactly cuboidal, but it's not too far off. If I were to tell you that's moderately differentiated, cell, what would you think of this cell right over here? That's a cell. Does it look well differentiated? If I showed you that cell in isolation, would you know it would come from the kidney? Do you know what its normal counterpart is? No. So this cell is so poorly differentiated, you don't even know where it came from. This cell is anaplastic. That is a level of differentiation that is so bad, so poor, you don't even know what the normal counterpart is. That cell is anaplastic. When you see a cell that poorly differentiated, obviously your first thought is going to be, well, that's a malignancy. Poor differentiation correlates with malignancy. The more poor differentiated the cells are, the more likely it's going to be a malignancy. Well, Neoplasia is about the poorest level of differentiation you can get. Questions on this? Okay. We also talked about mitotic figures, rates of growth. We calculate the rate of growth by calculating something called the mitotic index. Mitotic index is just the number of mitotic figures per unit area. Generally speaking, benign neoplasms, they grow relatively slowly, so the mitotic index is going to be low. Malignant neoplasms, they tend to grow more quickly, so their mitotic index is generally high. We also said that the mitotic figures of a benign neoplasm usually look normal. A mitotic figure that's normal is bipolar. Whereas a malignant neoplasm, you find one of mitotic figures in a malignant neoplasm, usually the mitotic figure is not normal. It's not bipolar. It's kind of bizarre looking. Let's take a look at that. Okay? Let's first take a look at a mitotic figure that you would find in a benign neoplasm. So here's a section through a benign neoplasm, and you can see a couple of cells here. And here's a cell right here in the process of dividing. You can see it's replicated its chromosomes, and it's dividing by pulling the chromosomes to one pole of the cell, and the other bunch of chromosomes to the other pole of the cell. This is a bipolar mitotic figure. This is the type of mitotic figure you'd expect to find in a benign neoplasm. And if you count up the number of mitotic figures per unit area, you get the mitotic index. It should be relatively low for a benign neoplasm. Malignant neoplasms, in contrast, generally they grow quickly. Mitotic figures are numerous. Mitotic index should be high. When you do find a mitotic figure, the mitotic figure is usually bizarre. That is, it's not bipolar. It could be tripolar. It could be tetrapolar. It could have 5 poles. Maybe it's pentapolar. Here's an example of a pentapolar mitotic figure. Okay. A lot of cells. This is actually a section through a malignant neoplasm called a Wilms tumor. It's also known as a nephroblastoma. It's a type of kidney cancer that develops in kids. You've got a number of different types of cells in here. Here's a cell that's in the process of dividing. There. And you'll notice it has 1, 2, 3, 4, 5. It's got a pentapolar mitotic figure in it. Is that a normal mitotic figure? No. That's a normal mitotic figure. It should be bipolar. This one has 5 poles. It's pentapolar. We'll describe this mitotic figure as being bizarre. A high mitotic index, bizarre mitotic figures, that correlates with malignancy. So when you see something like this, high mitotic index, very unusual looking mitotic figures, that correlates with malignancy. Questions on that? Next feature we talked about, local invasion. That's not a correlate. That's a defining feature. Any neoplasm locally invades, that is malignant. Okay, now, local invasion results in a neoplasm breaching natural tissue boundaries. A natural boundary. Usually the natural boundary that it tends to breach first is the pseudocapsule that surrounds it. When a neoplasm grows, pushes up against the surrounding tissue, remember it causes the tissue to atrophy. That creates what we call a pseudocapsule, rim of atrophic tissue. That's a natural tissue barrier. When a neoplasm starts to invade, the first thing it's going to do is punch a hole through this natural tissue barrier, the pseudocapsule. That's local invasion. And that has effects on the way the neoplasm will present macroscopically. Typically, you have a benign neoplasm. The boundaries are very sharp, very distinct. They're well circumscribed. You know where the neoplasm stops and normal tissue starts. That's because a benign neoplasm does not invade its pseudocapsule, its natural barrier that surrounds it. It's naturally delimited. Malignant neoplasms don't do that. Malignant neoplasms punch through that natural barrier, that pseudocapsule, making the borders very blurry. And so, very often when you look at a neoplasm macroscopically, just look at the borders. Are borders sharp? Are they fuzzy? Are they smooth? Are they irregular? If they're fuzzy and irregular, that's probably because the neoplasm is locally invading its own pseudocapsule, blurring the boundaries. Okay, well, we can see that. Let's take a look. Okay. Talked about that before. Here's an example of a benign neoplasm called a leiomyoma. It's a benign, smooth muscle cell tumor. Okay? This is a section through the myometrium, the muscular part of the uterus. And you can see some normal myometrium over here. And in the center of the section, you see this big nodule. This is the leiomyoma. This is a benign proliferation of smooth muscle. Now, when this benign smooth muscle proliferates, it can only grow locally because it's a benign neoplasm. It grows locally by pushing up against the surrounding tissue. And when the surrounding tissue is pressured, it atrophies and it leaves these rings of atrophic tissue around the expanding neoplasm. This is a natural tissue barrier. This is called the pseudocapsule. The pseudocapsule. It's a natural tissue barrier. If this is indeed benign, none of these cells should penetrate the pseudocapsule. These cells should only be able to grow within the confines of the pseudocapsule. And that's exactly what this neoplasm is doing. It's growing within the confines of the pseudocapsule. Notice how distinct the borders are here. Very sharp, well delimited. That's where the tumor is, that's where the tumor isn't. Very distinct. These borders are described as well circumscribed, well demarcated. Those are the phrases we use. Sharp boundaries. You'll also notice that the contour is not really irregular. It's kind of smooth contour. That's because the cells aren't invading, making the boundaries irregular. So typically benign neoplasms, very sharply demarcated, smooth boundaries. That's a result of a failure of these cells to locally invade. Benign neoplasms do not invade. However, malignant neoplasms do it. In fact, that's a defining feature for malignant neoplasm. Malignant neoplasm invades, well, by definition, that's what makes it malignant. Let's take a look. Let's compare. We showed you this one before. Here's a comparison, radiographic comparison of a benign neoplasm versus malignant neoplasm, showing you the distinct differences in the sharpness and contours of the boundaries of these two different neoplasms. Here's an example of a mammogram of a benign neoplasm called a fibroadenoma. Fibroadenoma. It's a benign neoplasm consisting of fibrous tissue and glandular tissue. It's benign. Right, take a look. You can see this woman in her breast has at least two fibroadenomas. One over here, and one over here. The whole thing. Notice this fibroadenoma has a very sharp demarcation. Boundaries are well circumscribed, they're well delimited, and look, the contours are very smooth. I would describe that as very smooth. All consistent with an absence of local invasion. That looks like whatever it is a benign neoplasm. It's a fibroadenoma. It is indeed benign. Okay? Absence of invasion. Take a look at this mammogram. This is a mammogram of a ductal carcinoma. It's malignant. There's the image of the breast. There's where the nipple is. Okay? Take a look over here. You can see this mass, this radiodense mass. Look at the boundaries. The boundaries smooth. Are those boundaries smooth? No, they're not smooth. Boundaries irregular? Yes, they are. Okay. Boundaries clear? No, they're very fuzzy. Look at all of that. That's clear-cut evidence of local invasion. That's a malignant neoplasm. It looks like it. Blurry boundaries, poorly circumscribed borders. That's due to local invasion. That's what a malignant neoplasm will look like. You can see just by looking at the radiograph, you can pretty much guess. That's probably benign, that's probably malignant. Just guessing based on the macroscopic characteristics, you'd probably be right 80, 90% of the time. Okay, one more characteristic we have to talk about. Metastatic dissemination. We said benign neoplasms do not metastasize. Malignant neoplasms have the ability to metastasize. They can detach from the primary mass, get into the blood vessels, lymphatics, and disseminate all over the place. That is a defining feature of malignancy. Benign neoplasms don't metastasize. Only malignant neoplasms do. Okay, well, how do they do that? Well, in order to metastasize, they have to get into the lymphatic system, or they have to get into the vascular system. That's one of the ways that they can disseminate all over the place. When they do this, we call it angiolymphatic invasion. The malignancy must invade the lymphatic system or the vascular system. But we can see that. We can see it histologically. This is what angiolymphatic invasion looks like. Okay? We got a section through soft tissue. Okay, there's some connective tissue out here, and it looks like right over here, we have a blood vessel. There's a blood vessel. I can tell it's a blood vessel because I can see endothelial cells over here. And it looks like we've got some RBCs over here. Look what's in the lumen of the blood vessel. You have, appears to be a lump of cells, all of which are very densely packed. That's a neoplasm. This is a neoplasm. It's in the blood vessel. How did it get there? It had to punch through the blood vessel. A piece of it broke off, and now this piece of tumor has become an embolus. This is a tumor embolus. It consists of neoplastic cells growing out of control, all very tightly packed together. And it had to invade the blood vessel. That's a malignant neoplasm. It's invaded the blood vessel. This is called angiolymphatic invasion, and this is one of the first steps in enabling a malignant neoplasm to metastasize to remote locations. You can actually see it. Here's the blood vessel. Here's the lumen. There it is, right in the smack middle of the lumen. That's a tumor embolus. Now, where is this embolus going to go? Well, it's going to, on the other embolus, it's going to travel distally through the vasculature until it gets to a point, maybe a small blood vessel, that won't let the tumor negotiate its lumen. And it's going to get stuck there. It's going to become impacted in some smaller blood vessel. Now, usually, these neoplasms will invade veins first, as opposed to arteries. The reason they get into veins before arteries is because a vein has a very thin wall, easy to penetrate. Whereas an artery has a very thick wall, very difficult to penetrate. So when cancers metastasize, they usually do so first by invading veins, walls of veins. So let's say this gets into the systemic venous system. Where is it likely going to get caught? Let's say it invades, let's say the inferior vena cava. Where is it going to get caught? going to get where? The pulmonary system. It's going to get caught somewhere in the pulmonary arterial system. It's going to have to go through the right side of the heart. It's going to easily get through the right side of the heart. Then after it gets through the heart, it goes through the pulmonary artery trunk. It's going to have to start traveling through successively smaller and smaller blood vessels in the pulmonary arterial system until it gets to the pulmonary capillaries, the smallest blood vessels of the pulmonary system. Very likely it's going to get caught somewhere before it gets to those pulmonary capillaries. Look how big it is. It's a couple of, several cells wide. It's probably going to get caught maybe in a pulmonary arterial or something. It's going to get stuck there. And so when a cancer metastasizes, breaks into a vein, it's very likely going to metastasize to the lungs first, because that's where it's going to get stuck. And indeed, that's a very common place for metastatic dissemination, is the pulmonary system. Okay? There are other veins that this thing can invade. Suppose it invades the portal venous system. Where is it going to get caught? The liver. The portal venous system drains into the liver. Got these big veins draining into the liver. They break up into smaller and smaller passageways until finally the blood drains into these sinusoids of the liver, the smallest of the blood vessels of the liver. Very well get caught in the sinusoids, or maybe some blood vessels just before the sinusoids. And so another target for metastatic dissemination is the liver. Cancers like to disseminate to the liver for the same reason they like to disseminate to the lungs. They're breaking into the walls of veins, and they metastasize, they embolize distally until they get caught in some smaller blood vessel. Let's take a look at what metastatic disease to the liver looks like. Let's first take a look at normal liver. Okay, here's a normal liver. It's cut transversely. You can see, looking at down the cut surface of the liver, there's the capsule of the liver right there. Okay, looks like you got right lobe, caudate lobe, left lobe there. This is normal liver. Got this nice kind of tan orange color to it. The color of the liver is not very homogeneous. That's normal. Usually the right lobe here is a little lighter in color than the left lobe. And that's because there's more fat over here. This is more steatotic. This part of the liver is more steatotic. Fat kind of yellowish, and as a result, that part of the liver looks a little lighter in color than this part. Everything's normal. You look down at the parenchyma, you can see some blood vessels here going through the liver. Okay? Everything looks good there. That's a normal liver. This is what metastatic disease to the liver looks like. This is actually breast cancer, metastatic to the liver. Again, you can see right lobe, left lobe there. This is a transverse section through the liver. Here's some normal liver over here. Okay? But then look around the other parts of the liver. What do you see? Look at these little spots here. Kind of bright spots. Those are metastatic foci. These are areas where the tumor embolus got caught in the sinusoids of the liver. They impacted and they started to grow. They had nowhere else to go, so they grew there. They grew and started to infiltrate the liver. Now, each one of these little spots represents a tumor embolus. It's a separate colony of tumor cells. When emboli enter the venous system, usually there are multiple tumor cells that get into the venous system. They travel distally and they spray the liver with tumor emboli. And each embolus getting caught creates a separate colony of tumor cells. So we have many different metastatic foci here. Now, take a look at those colonies. Take a look at that one. Those boundaries look sharp to you? Those boundaries look sharp? No. That's because the tumor cells are invading the liver. And they are creating very blurry boundaries. Now, some of these are kind of unusually sharp, but most of them that's blurry. That's because the tumor cells are growing and they're just invading everything. And so those metastatic foci have very blurry and unclear boundaries. Okay. So I said that this was actually breast cancer. How do I know that these are not primary sites for liver cancer? How do I know that's something other than liver cancer? How do I know that's metastatic disease? How would you know that this is breast cancer and not primary liver cancer? You can do that, but just let me rephrase my question. Just by looking at this specimen, gross specimen, how would you know that this is not primary liver cancer? There are a lot of them. Look at this. Look how many foci you have. Those are all colonies. When cancer develops, usually it develops as one primary. One cell loses proliferative control and gives rise to one primary mass. And so if this were liver cancer, you'd expect maybe there'd be one big mass in the liver, not 20 of them like you see there. If it were one big mass in the liver, I'd say, gee, that's probably primary liver cancer. It's probably hepatocellular carcinoma. But because there are many foci here, that's probably not primary cancer of the liver. This turns out to be breast cancer. Now, we call this breast cancer metastatic to liver. If you're asked what kind of cancer this is, you wouldn't say liver cancer. You'd say breast cancer metastatic to liver, because the primary is in the breast. If you were to palpate the breast, you'd find one lump in the breast. And it looks like those cells detached, got into the vasculature, and disseminated to the liver. So this is breast cancer metastatic to liver. Okay. So what if I asked you a question? I said a radiograph was taken of a woman who's been losing a lot of weight lately. She's been coughing out some blood. Take a look at that radiograph and you see 10 different foci in the lungs. And I ask you the question, is that lung cancer or is that metastatic disease? Metastatic disease. Too many foci. It's probably not a primary lung cancer. Okay, any questions on that? I can't really emphasize the importance of that chart we've been discussing. Just a few more things about metastatic dissemination. We've been talking about metastatic dissemination in terms of blood vessels and lymphatics. Those are really the primary routes of metastatic dissemination. It can spread lymphatically or it can spread hematogenously. Generally speaking, there is a preference as to what type of cancer will metastasize in what way. Remember we talked this morning about sarcomas and carcinomas? Carcinomas evolve from, what's a carcinoma? It generally arises from one of those three germ cell layers, ectoderm, mesoderm, or endoderm, and what's a sarcoma? Comes from mesenchyme. Fibroblasts come from mesenchyme. So anything comes from mesenchyme is a sarcoma. Anything comes from those other three germ cell layers to carcinoma. Carcinomas tend to like to metastasize via the lymphatic system. So if you had to guess how a carcinoma metastasizes, you'd say lymphatic system. There's a propensity for it to invade the lymphatic system. Sarcomas, in contrast, tend to metastatically disseminate via the hematogenous route. They tend to invade blood vessels. Now, there's one other way that a cancer can metastasize. It can metastasize by spreading out in the bodily cavity. It breaks through whatever containment, whatever pseudocapsule it has, and it spreads in a bodily cavity. Ovarian cancer is a good example. Ovarian cancer usually breaks out of the capsule, spreads throughout the peritoneal cavity. That's considered metastatic dissemination as well. Okay, a couple other things we need to know. Usually, not always, but usually, when there's a cancer developing somewhere in the tissues, you can predict where it will metastasize first, just based on some simple mechanics. First, you look at the tissue and see what lymphatic system drains the tissue. If it's a carcinoma, probably is going to break into that lymphatic system and drain via that local lymphatic system to the regional lymph nodes first. That's where it's going to metastasize first, the regional lymph nodes. So if you have a breast cancer, hey, there's a lump in the breast. You palpate a lump in the breast. What's the next thing you're going to do?
Go get a mammogram.
On your physical exam. Axillary lymph nodes, because a large part of the breast is drained by the axillary lymphatic system. If that cancer is going to metastasize anywhere, it's going to be there first. So that's why you feel a lump in the breast, you're going to go in there and you're going to palpate those regional lymph nodes. So if it's going to metastasize, it'll probably go to the axillary lymph nodes. If it goes to the axillary lymph nodes, the lymph node architecture gets effaced and destroyed, and the lymph node gets big, and you can palpate it. You'll have enlarged lymph nodes. Okay, simple mechanics like that you can use to predict where cancer is going to metastasize to first. Some cancers, though, don't seem to obey simple mechanics at all. In fact, they seem to home in on specific tissues, regardless where they grow. A good example is malignant melanoma. A malignant melanoma, that's a skin cancer. Skin cancer, say, growing on the leg, it tends to metastasize to brain first. They can't really explain that with simple mechanics. It seems like a malignant melanoma zeroes in on the brain. It grows on the leg, it'll go to the brain. It goes on the arm, it goes to the brain. Why is that? That phenomenon is called tropism. Tropism, or homing. It homes in on a certain tissue. You can't explain that with simple mechanics. What actually happens is that the malignant melanoma gets into the vasculature, gets in the lymphatic system, it disseminates all over the place. But the implantation conditions are favorable best in the brain. And so, yeah, it goes everywhere, but it tends to implant in the brain first. And so that's where the metastatic disease tends to show up first, in the brain. That phenomenon is called tropism. It seems to defy the simple mechanics. But in reality, the cancer is metastasizing everywhere. It just happens to implant first in the brain. Okay, any questions on that? Any questions on this chart? Really important chart. So you know what a mitotic figure is, right? You know what I mean by mitotic index. You know what anaplasia means. Okay. All right. Good. That's it.